The neurological examination of legs helps identify conditions like paraplegia, ataxia, Guillain-Barré syndrome, and neuropathies. Start with a general inspection for muscle wasting, fasciculations, and deformities. Assess gait and balance, including Romberg's test to evaluate ataxia. Test muscle tone by passively moving the joints and look for spasticity or flaccidity. Evaluate muscle strength using the Medical Research Council MRC scale. Reflexes, including the knee jerk and ankle jerk, should be tested for hyperreflexia or hyporeflexia. Sensory examination involves testing for light touch, pain, temperature, and proprioception. Coordination tests, such as the heel-to-shin test, are crucial for detecting ataxia. For conditions like Guillain-Barré syndrome and neuropathies, nerve conduction studies and electromyography (EMG) are valuable diagnostic tools. MRI is helpful in conditions like spinal cord compression and multiple sclerosis.
After introducing yourself, the first thing is make sure that it's proper exposure. So ask your patient or help him to expose the required part. It must be at least up to the thighs. Better if you expose further.
किसी जगह आपको कोई दर्द तो नहीं कोई किसी जगह कमजोरी तो महसूस नहीं करते ठीक
The first thing is you inspect carefully, inquire about any discomfort or any pain patient may be having. Carefully note for any abnormal spontaneous movements or tremors or involuntary movements. Note the posture. Check for the muscle tenderness. Check for any fasciculations by eliciting tapping over the muscles. Check for the bulk of the thighs, mid thigh level, and maybe mid calf level. Again, you can use an estimation by using your hands or properly measuring it by using a measuring tape. Check for the tone by passively moving the limbs. It's better to check tone at each group of muscles and each joint. Now this is checking the tone of the flexor and extensors of the knees. This is flexor and extensor, dorsiflexor, plantarflexor of the ankle, flexor and extensors of the knee and then the ankle. Start checking for the power. Now this is checking the power in the feet, the dorsiflexors and the plantar flexors, everters, and the inverters of the foot. You can move proximally of flexors of the knee, flexors of the knee, extensors of the knees, knee extensors. This is checking the power in the flexors of the hip, flexors of the hip. This is abductor at the hip, abductors of the hip. This is extensors of the hip or glutei. If your patient can resist against your hand, the power is 5 by 5. Checking for the reflexes. This is the knee reflex, striking over the ligamentum patelli below the patella and noting down the contraction of the quadriceps, striking at the Achilles tendon by holding the foot a bit slightly stretched and striking over the stretched tendon. This is the ankle jerk, demonstrating the knee clonus or patellar clonus by forcefully stretching the quadriceps tendon and then holding it there This is demonstration of how you check for the ankle clonus by giving 2-3 jerking movements and then keeping the uh, foot in the maximum stretched positions of the Achilles. Now you move on to check for the sensations, but before that we are going to demonstrate how to do the Webinski sign or planters. So move some sharp object along the lateral border of the foot and then move it across the sole to the till the big toe, and notice for any movement of the big toe. Normally there should be a downgoing movement, but if it's an abnormal or upper motor neuron, the big toe would move up and the fingers would stretch. Now this is again, now we are checking for the coordination.
अच्छा जी, अब आपने ये
This is
काम को
demonstration of heel
इसको
shin
पहले
knee
निकाल
test.
लेना है, फिर
You
इसके ऊपर
explain to the
एक फिर वही
patient that
वापस यहाँ पे
first he has to lift the
जब
limb
मैं कहूँ
up,
एक, तो आपने मेरे हाथ को लगाना
touch
है,
your hand,
दो
then
एड़ियाँ लगानी है, तीन पे इस पे रगड़ के,
touch the
चार पे इसको वापस
opposite
पहले
knee
दाईं टांग से
with
करें,
the
एक,
heel of the opposite
दो,
foot,
तीन और चार,
move it
फिर
across the
वापस
shin, and then place it back
एक,
to the position. So this is the
दो,
4 component
तीन,
elevation up to
दूसरी टांग से कीजिए, एक,
touching the
दो,
knee, moving over the shin, and then placing it. So if you can do this without any clumsiness, then there is a good coordination.
महसूस ठीक हो रहा है आपको?
Now, grossly checking for the sensations now. Explain to the patient that
ये क्या लगता है?
this is the kind of touch you would be feeling, explaining it by touching it over the face.
आपने मुझे ये बताना है कि कहाँ लगा?
Now touch it one by one at each segment. Now this is the sole of the foot, which is represented as its S1 segment or sacral 1 segment.
अब अब अब
Now moving it medially, this is
अब
inner part of the shin, which is L4 segment, lateral part is L5 segment, back of the calf is again up to the knee is S1 segment or sacral 1,
अब
above the knee, back of the thigh would be S2 segment, and up to the glute med S3 segment. Now this is the lumbar 1 and lumbar 2 segments up to the inguinal ligament, and if you move further up, it would be the thoracic segments in the abdominal wall. After the soft touch, you now check for the pain. The pain usually using a slightly sharper object, which gives a sense of prick or a pain. So using this toothpicks, you again follow the same scheme with each dermatomal pattern being touched and asked that the patient feels a touch feeling or feels a prick feeling or a pain feeling. The loss of pain would be absence of sensation in the spinothalamic tracts. Loss of this
थोड़ा सा मुझसे
touch would be the dorsal column tracts.
अब कहाँ लगा?
So you move it up to the umbilicus level, because this is T12 level, is at the level of the inguinal region, and T10 is usually the umbilicus level.
काम कीजिए थोड़ा सा करें.
Demonstrating the abdominal reflexes. So moving the sharp object from lateral to the medial part in 4 quadrants, and noticing the movement of the umbilicus towards the touched part. If it is absent, it's again one of the signs, upper motor signs. This is demonstration of how to check for the vibration. First, make your patient explain what kind of feeling or sensation he has. Strike it against your hand. When they start vibrating, then you touch it over the big toe at the bony prominence or at the joint. And not only that, you ask for whether patient feels vibration, but you, with your hand, you just touch the prong so that the vibration stops, and we ask the patient whether he still feels this vibratory sensations or not. So feeling it and not feeling it when it is not vibrating is important. You can move up if there is no feeling in the big toes, you can move up to the malleolus and maybe up to the knee as well. This is checking for the joint position sense. You explain to the patient with an open eyes that this is the thumb, big toe upward and downward, and then you ask your patient to close the eyes and then move it after a few jerky movements, whether the final position of the big toe is upward and downward, and look for whether he correctly describes it or not. If he makes a mistake more than twice or thrice, that it is down, and he says it's up, it may be that he is not. Then again, another method is that you place the limb in a position, and with the closed eyes, the patient is asked to place it.
Neurological examination of lower limbs involves a systematic approach to assess various functions, including tone, power, reflexes, and sensation. Key steps include inspecting for muscle wasting or fasciculations, testing muscle tone, noting spasticity or flaccidity, evaluating muscle strength, and checking deep tendon reflexes. Sensory examination covers light touch, pain, vibration, and proprioception. Differentiating between upper motor neuron UMN and lower motor neuron element paraplegias is crucial. UMN lesions, typically located in the brain or spinal cord, present with increased muscle tone, spasticity, hyperreflexia, and a positive Babinski sign upgoing toes. In contrast, LMN lesions affecting the anterior horn cells, nerve roots, or peripheral nerves manifest as muscle atrophy, fasciculations, decreased muscle tone, flaccidity, hyperreflexia, and a negative Babinski sign downgoing toes. Understanding these distinctions aids in localizing the lesion and guiding appropriate management.